So I'll be brave if you're brave. I'll be brave, but only if you're brave.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. I'm so happy to see so many familiar faces in the room. Welcome to all of you and all of you who are watching from your own living rooms. We couldn't be more thrilled to have you all here tonight. As many of you have seen, tonight's discussion is going to be about precision oncology and what it means to you. For those of you who may not know me, I'm Danielle Hicks. I am Chief Patient Officer here at GO2 for lung cancer, and that's just really a fancy way of saying that I oversee a team of really amazing humans who help to pull together programming like this for all of you. And I love my job. I say that all the time. I love my job. I've been doing this for almost 20 years now, always in this same type of a role. And the living room's actually been around since 2009. So we're coming up really quickly on 20 years of this programming. And this programming is really built with the lung cancer community in mind, specifically people diagnosed with lung cancer and their loved ones, to bring to you live and in real time conversations and talks from key opinion leaders in the space across varying aspects of the disease. So we couldn't be more thrilled tonight to have Dr. Heather Wakelee, who is a veteran to the living room. This is not her first rodeo here, and we are so thrilled to have her back. And Dr. Bryant Lin, who is new to the living room. This is his first time here, and we hope we have him back as well, both from Stanford, right down the road. And I'm not going to run through big bios and bore all of you with that kind of stuff, but I am going to open the meeting and ask both of you, and Dr. Wakelee, we'll start with you, about why is lung cancer an area of focus for you?
That is a fantastic question. I don't think I've been asked that for a while. So when I was in medical school, I knew I wanted to go into oncology. And when I was starting through some of my oncology rotations, knew that I wanted to work in the solid tumor world, because there was, at that time, which was a while ago, we just didn't have a lot of options. And then when I was in fellowship, I got invited to a conference that was focused in lung cancer. And the people who at that time had chosen that as a career were my people. We just didn't have a lot of options. So the people who had gone into that world were with that same motivation of, this is a field where we need more people who are really dedicating themselves to do more. And then it was right at the time that things started getting exciting. So we still had chemotherapy when I started, but it was the first EGFR drugs were just coming out, and we didn't know who they were working for, but we knew that they were starting to work. And then all of the stories evolved from there about why they work and how they work, and then the idea of what else can we figure out. And now we, of course, are in a very different world with more hope, and it's really exciting. But I started off for all those reasons. So, yeah.
I love it, and we couldn't be happier that you're here. I've had the pleasure of being on the road at several different conferences over the year and seeing Dr. Wakelee speak, and she's really truly an inspiration and teaches so many who want to know more about lung cancer. So thanks for everything you do. Dr. Lin, how about you?
So about 7 years ago, I had a patient who was impacted by a medication I gave him, and he had a severe reaction. And that led me to co-found with my colleague, Dr. Latha Palaniappan, the Center for Asian Health Research and Education, because medications are metabolized differently by Asians, and certain diseases impact Asians differently. And one of those diseases is lung cancer, EGFR mutated in particular. Fast forward to last year, and around this time, actually, I started to develop a cough. It was a nagging cough. I thought it was allergies. Cough got worse and worse, tried different things. Luckily, my PCP is in the same office as me. I'm a primary care doctor. And worked on different things, tried inhalers, antibiotics, finally got imaging, got an x-ray, which showed a large opacity in my right lung, and got a bronchoscopy, which showed I have stage 4, and PET scan, which showed I have stage 4 lung cancer, non-small cell lung cancer, adenocarcinoma. And then it turns out I have EGFR mutated lung cancer, exon 19 deletion. So I have ironically become a poster child for a disease that my center that I co-founded was really dedicated towards supporting research and education around. And I'd already known Dr. Wakelee from those efforts before I was diagnosed. And thankfully, Dr. Wakelee agreed to be my oncologist. So I'm getting amazing care at Stanford.
Of course you are. Before we jump into your diagnosis, because I do want to take a deeper dive into that, can you talk a little bit about the work that you were and continue to do?
Yeah, so there are many diseases that differently impact Asians. In particular, it's funny, after I was diagnosed, I looked back in our emails and in our kickoff in 2018, so almost 7 years ago, we had a talk about one of our colleagues, Professor Ann Singh, was talking about in her presentation screening for lung cancer in non-smokers. And we've awarded various seed grants. We've tried to sponsor research in those areas, having community talks. I think Dr. Wakelee gave one of our community talks. About 2 years ago, we made lung cancer in Asian non-smokers a priority area. So we really wanted to focus our efforts of raising funds, having more seed grants, and most recently we had a lung cancer summit. So, I think the attention my case has brought more resources to the effort. So I'm glad for that.
And when we think about, we could go to like 25 different ways here, but when we think about lung cancer and never smoking, particularly Asian women,
yes,
right? There's a higher propensity there.
Yeah.
Can you talk a little bit about that?
Roughly double the risk of some non-Asian women groups have higher risk. Asian men, there's some kind of studies now looking at the propensity for Asian men. One thought has been Asian men, there's a higher smoking rate among Asian men, so maybe there's some kind of hidden cases there that we didn't know about. One way to think about it. But definitely in terms of the mutation, the tumor mutation I have, anywhere 50%, 40 to 50% of Asians have this tumor mutation, whereas other groups can be less than 20% have this tumor mutation. So it definitely differently impacts us, but definitely Asian women are at higher risk.
And how might some of this research or this work impact, you touched on it, but screening? Because right now, screening guidelines say you have to be between 50 and 80,
and be a smoker.
And be a smoker,
Yeah, absolutely. So, this is a big challenge. I'm a primary care doctor. Yeah. A lot of what I do is screening, right? Screening falls on the primary care doctors. And, there's this great study that came out last year, maybe the year before last year now, called the Talent Study in Taiwan. They studied a population of people at risk, people who had a family history, secondhand smoke exposure, poor cooking, ventilation, and they did low-dose CTs on this group, and they found roughly a 2% detection rate. So out of 100 people they screened, 2 of them would have had lung cancer, would have been diagnosed with lung cancer. And just as a point of comparison, in the smoking population, it's roughly a 1% detection rate, so about 1 out of 100. So this is relatively new data. As you all know, from your great work here, it takes years, unfortunately, to develop guidelines, and the level of evidence is quite high. So that's a challenge. Also in the U.S., speaking from an Asian health perspective, a lot of the guidelines don't focus on smaller populations, so that's also challenging. But hopefully, we have enough population in the U.S. and enough momentum behind this effort to get screening covered, because right now it's not covered, as you said. Yeah. Right now, just kind of tell a side story. One of my friends, his parents were both diagnosed with lung cancer, and they were non-smokers, Asian, and he wanted to get screened. So actually, he found a Groupon which covered his CT scan for $200. So he was able to get screened because of that. So there are challenges when insurance doesn't cover screening.
Yeah. It's interesting because I know my own mom, for those of you online who can't necessarily see her right now, but Bonnie Dario, co-founder of GO2, was diagnosed in 2003. She had actually been misdiagnosed for about 1.5 years, and ultimately was sort of told that it was psychosomatic, like we cannot find anything wrong with you. Nobody had ever done a CT scan on her, but she had serendipitously sort of found a CT screening, like one of those full body, and she went down and had that done, and that was ultimately how they. Yeah, it was not $200 with a Groupon. It was $1,700 out of pocket. Yeah, but it's so sad because I think still today, here we are, 2 years later, and people who are concerned about their risk either because of family history or other exposures, or who knows, don't really have any options. So the work you're doing is so incredibly important, so that we can open up those screening guidelines. So let's jump a little bit, not a little bit, a lot of it, into your own diagnosis. How did that sort of begin for you? I know you gave us a brief little snippet.
Yeah, it's again, as a primary care doc, we do most of the diagnosis because people come to us when they don't know what's going on. And cough is common, right? People come with cough, right? I mean, I'm sure out of this room, most of us have had a cough within the past 6 months, right? And I have a long history of allergies, so I thought nothing of it. I thought, it's just allergies, and I didn't have any history of asthma. So, tried different inhalers, tried to treat it like it was asthma, took allergy meds, treated my post-nasal drip with nasal sprays, and still didn't get better. And again, I have great privilege. I have access to my doctor, again, sits like a few offices down from me, right? Mm-hmm. And, I said, geez, it's not getting better. Dr. Paul Ford, excellent doctor. And he said, okay, let's order a chest x-ray. I even went to a friend of mine who's an ENT because I felt like my vocal cords, I had some sounds when I was breathing that we call stridor. And I thought, geez, maybe it's an upper airway issue. He was very kind, took a look, wasn't that. X-ray showed a big opacity in my right side. Very quickly got a CT scan the next day, showed, again, concern for mediastinal, so lymph nodes in the middle of my chest. And then that Friday, again, because I have great privilege, got in for bronchoscopy because I've been working at Stanford for 20 years, so I know who to, pick up the phone and call, right? And that Monday, I had my pathology back, which showed adenocarcinoma. So that was 6 days from chest X-ray to pathological diagnosis. It's funny, we think about pathology, it's like we have to tell patients, 3 to 5 days, right? Take some time. And, that, it's like a world record pace. But to me, just speaking about access, that should be the rule and not the exception, right? So that should really be the rule, is that everyone should get diagnosed as quickly as I was diagnosed. And it can be done. Clearly it can be done. So, thankfully I was able to get a PET scan relatively quickly. It showed that I had 50 metastases to the brain, which to me, I'm like, I've seen lots of patients with cancer, and got poor radiologists had to sit there and count 50 spots to the brain. And he counted, he's like, 50 metastases to the brain. And that really shocked me, and then I had spread to my bone, spread to my liver. I even had little lumps under my skin, which I thought, maybe they're lymph nodes. But again, went to our fine needle aspiration clinic run by our pathologists, and in real time, they poked at them and said, no, these are not lymph nodes. These are just cancer. It's just adenocarcinoma under your skin. I was, of course, very shocked. Shocked by, I was 49 at the time. I'm 50. Again, at the time, I didn't know I had a family history, but later I found out that an uncle was diagnosed with very early stage, just incidentally found adenocarcinoma. And, started on treatment right away. I had a little hiccup there. I was very allergic, it turns out, to one of the anti-nausea medications. Oh, no. So this is right before Memorial Day last year. So I had to be admitted. And then I started, Heather called me and says, well, you got your Tagrisso, right? You got to start that right away because this is a delay in treatment. And I started and luckily, responded to treatment. And, I'm the beneficiary of this basic research that all of you have supported. EGFR inhibitor, I wouldn't be here. I mean, I graduated from medical school 23 years ago. If you'd asked me then, geez, you've got a patient with stage 4 lung cancer, metastases to the brain, to the liver, to the bone, and he would be sitting in front of you, streaming to the world, speaking, not coughing, gained weight back. I'd said, you're crazy. No way. Almost 1 year after my diagnosis. And this is a tribute to all the work you've done to support research, basic science, which have developed EGFR tyrosine kinase inhibitors to treat EGFR mutations, but also clinical research. So I'm the beneficiary when Dr. Wakelee told me, oh, well, there's a study, this FLORA-2 study that came out, which showed that chemo plus Tagrisso, osimertinib, is better than osimertinib alone for people like you. I've got a high performance status. I'm a young, relatively young, didn't really have any medical problems, so could tolerate chemo presumably reasonably well. So for me personally, I fit kind of the categories, the inclusion criteria of that study. And I responded after 2 cycles, MRI, could not detect any metastases, so in the brain. Still have the lung, still have the lymph nodes, the liver, but the brain metastases were gone. And, really a tribute. I'm living, breathing example of how basic and clinical science can help a patient.
Yeah, I think it's important. Your entire story is incredibly important for so many reasons. You spoke about great privilege, and I think folks in the room, online, and those who will come back and watch this post live, their story doesn't look like that, right? Too many of them, and I know when we get into Dr. Wakelee's part of this conversation, we're going to sort of talk a little bit about what good looks like, but we know that that's not always the case. But you said it loud and clear, and we're going to quote it after this meeting, like it can be done, right? So we have to find better ways, in my opinion, particularly in the community setting in some more rural areas, to help support these general oncologists and these smaller, hospitals and cancer centers, so that they are able to provide this type of service to them. And that is some of the work that we do. So let me ask you a question. Given that you had been working in this space, and prior to that CT scan, did it even cross your mind?
No, not at all.
No.
Not at all.
No.
Yeah.
Which is interesting. I do want to remind everybody that this is an open forum. Please feel free to ask questions, interrupt at any point. Same goes for people watching online. Michelle's over there monitoring the online chat. I was remiss in not mentioning that in the beginning. Oh, hi, Francis, in the corner. No, it's on.
One question. Were you ever scared?
Absolutely. Absolutely, without a doubt. We talk about the stages of grief. I went through those at least twice, maybe more. I was definitely scared before bronchoscopy. I hate procedures. I hate procedures. It's always funny, right? Doctors. Yeah. I hate procedures. I get very anxious. My blood pressure goes up. Even to this day, I've had 14 cycles of chemotherapy, and my blood pressure still goes up. I still get a little bit anxious. So yes, absolutely. But that's to me, that's normal for me. Yeah. Right. And you find a way to manage that, right? That fear.
How do you manage it?
Well, again, I'm greatly privileged. I have great, fantastic doctors, right, who are always available, to listen, to talk. I have a fantastic support system, right? Got a great job that's flexible, right? So I have all of these things that are helpful for me. I speak English. I don't need a translator. I have transportation. I can, I have good health literacy, presumably. So, all of these things are what were in my favor, right? Yeah. But yeah, I just wanted to point out, Stanford's doing great things. Led by Dr. Wakelee in terms of diagnosis. So there's actually a new diagnostic clinic, which is amazing, right, to hear. Because traditionally, the diagnosis gets done in primary care. And in primary care, we've got a lot of things to do at any particular visit. Like if you just looked at screening, I think somebody calculated, geez, you'd be 24 hours in clinic every day if you just went through all the screening tests we have to do. So I think, those initiatives like having diagnostic clinics in the oncology center are really crucial for patients, who are having these challenging diagnoses.
Yeah, it's interesting because when I think about lung cancer, and diagnosis, and in spite of the fact that we've had screening for many years now, we're still seeing pretty small numbers of the people that even qualify with the limited guidelines going and getting screened. Do you have any thoughts on?
Oh yeah, at Stanford, we look at those numbers all the time in primary care because we think about how, and we work with our thoracic surgeons. There's a lung cancer screening clinic. And so, it's a collaboration because we see the patient, right? But we've got to kind of refer them or have them see them. There's different ways on the electronic medical record we can capture that. But, our information is incomplete. Some people don't tell us they smoke. Sometimes we don't ask, or we didn't capture that information, or it's inaccurate, you know. So, there's a lot that can be improved.
Yeah, I feel like screening for lung cancer took a minute to catch on in the primary care world, particularly in the community setting. And I remember, I'm going to digress for just a second, but I remember being at my own primary care, I can't remember what it was for, and they had this big, beautiful poster up on the wall in the exam room, and it was like, birth to XYZ years, here's all the vaccines you need, and it went all the way through. And then when it got to the 50 to 65-year-olds or something, it had, your colonoscopy and your mammogram, and lung cancer screening was not on this big, beautiful poster. And I, quite frankly, lost my mind, and I called the marketing department in the hospital. I was like, maybe it's just a dated poster. Nope, it was printed this year. They quickly adjusted the problem. But I think even now, where it is more broadly talked about, I think there's still some fear, because when we're talking about the population of people who do qualify, they still do have sort of this shame, blame kind of psychological thing going on in their head. And I know we try really hard here to get people out of that space to say, no, 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 because if we can find it early, right, all the better for you. So just a little push for screening for anyone out there who may qualify. And I know we talk about it quite a bit even in this programming, in spite of the fact that it is built and created for those people already diagnosed. Who better to shout from the rooftops information about screening than people with lived experience, right, who are sort of walking billboards for why it's so important.
Absolutely, absolutely.
So I want to talk a little bit about, I've done a lot of reading about you and watching videos and all the things, because I am so incredibly inspired, not only by your story, but by your attitude and some of the choices you've made in how to take on this diagnosis and how you are giving back. So can we talk a little bit about what you're doing right now and some of the advocating you're doing and teaching?
Yeah, sure. So, I'm always a big believer of, something bad happens, try to turn it into something good. There's the old adage, right? When life gives you lemons, make lemonade. I think my colleague heard a better term. It says, when life gives you crap, make fertilizer. So
there it is.
I like that. That's maybe a little bit more appropriate. So, I decided early on, and, I looked through my emails because when did I think about this? So I was diagnosed in May, started treatment right after Memorial Day, which is the end of May. And then in June, I was already emailing my students about starting a class around lung cancer around my case. I thought this was a unique opportunity that I would have loved as a student or even as a resident to hear from somebody who's got a foot in both worlds as a physician but also as a patient. And I felt responsibility as one of the leaders of our Center for Asian Health to really bring attention to this, right, to use my case. And it kind of like, as you alluded to, I did feel like there is a lot of stigma against not just being diagnosed, but also like the process of, being diagnosed. But, once you have cancer, a lot of people don't feel like they can talk about it. And I wanted to, reduce that stigma for people who could benefit from talking about it. It's not for everybody. It's not for everybody. And so, we started this class, and it came to get together really very quickly because we had so many people in our community already. Actually already knew everybody who came to speak at her class pretty much. Dr. Wakelee kindly agreed to give one of the lectures. We have this great expertise at Stanford, so we can call on different people. But, one thing I learned as a patient, and I knew this before as a doctor, but, you don't really know until you live that. was the proportionality of the experience. As a doctor, you see the patient in the clinic, you see them, or on video, you see them, getting treatment, they get tests. I mean, you may not see them there, but they get treatment, they get blood draws and tests. That's a small percentage of their life, right? Most of their time, it's about, what do I eat today, right? What do I eat for breakfast? Geez, I don't feel well. What do I do about it? About caregiving, right? How do I get the support I need? How do I get access to the care I need? But also around things like mental health, right? Who do I talk to? How do I manage this? How do I manage the fear, right? Feeling scared, right? And then also the spiritual side. I'm not a religious person, but having so many people reach out to me saying, I will pray for you. I'll pray with you. I'll light a candle for you. I had people sending me Hindu chants, Buddhist chants. It's amazing, and it's amazingly comforting to me. So we designed the class around that. So half of the sessions were really around those really human sides. I mean, we get a lot of science teaching already at Stanford. So, the class was really targeted for medical students. And it's online, so if you want to watch it, the CME, our Continuing Medical Education Office, was very kind and did some light editing and put it online. So if you want to watch it, keep in mind, again, it's targeted to medical students.
Yeah.
But I think hopefully that gave them a different perspective of what it's like to be a patient. So, every week I would talk about what was going on with me as relevant to the topic. First session we had Dr. Paul Ford, my primary care doctor, come in and, I showed images of my PET scan, of my X-ray, and my CT. We had Dr. Natalie Louie who talked about screening. It's amazing, went on from there. And, Dr. Wakelee gave a great session on treatment. And then our last session was fantastic because we had two, our oncology colleagues talk about kind of the future. What does the future look like? So we had, I think, a great, well-rounded class, but really focused and rebalanced around what a patient goes through. It's interesting, you think, all of these topics are not necessarily relevant, but they're really relevant, spiritual care, right? I mean, that's at least as important as the other treatment I get as a cancer patient, right? Nutrition, right? And we have great dietitians at Stanford, but it's something you deal with literally with every bite you take, right? How do I feel? How's this making me feel? What should I be eating? What should I not be eating, right? Yeah. So there are all these issues we grapple with that are so important.
Yeah, and I think it's incredibly important for healthcare providers to be taught this type of thing, right? Because I think historically you're focusing on the clinical aspects and that sort of thing and not treating the whole person, right? And we preach here all the time about what it means to treat the whole person. And as you pointed out, everybody's needs are different, right? Everybody has different ideas about, and different coping mechanisms and the like. GO2 has a program called Mind Over Matter, where it's a 5-week, 90 minutes a week program for patients and caregivers to help teach them tools on dealing with some of these big feelings that you're talking about, right? And I know it's a challenge in my own personal experience with my mom and other family members being diagnosed with cancer. They don't want to be a burden, so quite often they're not even sharing some of these things with their caregivers and trying to deal with them all on their own. And then their caregivers are having their own sets of issues that they don't want to burden their loved one with. And so it's like this vicious cycle. So, and we also know that patients listen to their healthcare providers. So if their healthcare providers are the ones bringing this type of information forward, talking about the importance of this whole person, sort of experience or treatment, I think it makes all the difference in the world. So I love what you're doing. Your future generations of providers who are really going to be thinking bigger and outside of just the clinical aspects of this.
Yeah, I mean, that's my hope, yeah.
Yeah. Does anybody have any questions? Michelle, are we good? I just want to do a quick check-in. We're good? You're typing away, answering somebody about something. So now I want to jump into a little bit about what is precision medicine. You guys hear us talk about it all the time. It comes by many names, right? personalized medicine. And you guys have also heard me say here before that lung cancer is an incredibly complex disease, and it gets more and more complex every day as the research is being done and new discoveries are being made. But it's really about treating the person as an individual, right? I remember when my mom was first, I keep pointing over here, but when my mom was first diagnosed, targeted therapy wasn't a thing. EGFR was still in trials. And it was sort of like throwing pasta at the wall and seeing if it stuck with a chemo and radiation. Through a series of incredible serendipitous events, she's here and she's come on to do some really amazing things for people in this community. But it does get more complicated. And when we're talking about getting online and health literacy and people really trying to understand what's going on, it gets even more complicated with all of these big words and why somebody might be getting X treatment and I'm getting Y treatment, but we have the same mutation, but, right? So not everybody's treated the same, and that's what we want to see. So Dr. Wakelee, what, in your words, because I just kind of shabba-labba all over that, what does precision medicine mean to you?
It's about identifying specific aspects about the tumor and about the person who has the tumor that help to guide the treatment. So with the tumor, I think most people understand that a cancer is one of our own cells that's sort of gone bad. You know, something has changed in that cell that allows it to grow and divide and not be killed by our usual ways that we would kill something that shouldn't be there. So it figures out how to keep growing, not go through its normal death pattern, and avoid being attacked by the immune system. And for some cancers, there are a lot of things that have happened that have led it to be different. And for some cancers, there can be a single change in one gene that happened in a cell that then gave it an advantage where it could just keep growing and dividing and growing and dividing, and then all of its daughter cells, I don't know why they're female, but they are daughter cells, they all have that specific mutation, which also allows them to kind of keep growing and dividing. And then over time, other things happen and they become more and more complex. But when there are these simple tumors, those specific things are things where we can identify them, and that's EGFR was the first one found in lung cancer. And it is still the most, it's not necessarily the most common, it's the most common in some groups. But so we know that for some people who get lung cancer, and this can be in people who've never smoked or in people who have smoked, even someone who develops lung cancer who has never smoked, it's more common to find one of these. But even in people who have a smoking history, we can, and we just need to always know to look. And so in lung cancer treatment now, when we talk about personalized or precision, it's standard of care, right? If someone is diagnosed with lung cancer and we don't do the testing to figure out what makes their cancer a cancer, how is it different from the rest of their body, then we aren't necessarily treating them the right way. And so going back in time, right when I was starting my career, unfortunately right around the time you were getting your diagnosis as well, yeah. People we had the chemotherapy and then recognized that its protein, EGFR, was found in the lung and not in other places except the skin. And so if we could shut that down, maybe that would have some impact on lung cancer. And lo and behold, it did. It would actually dramatically shrunk tumors in some people, and ended up being about 10% of people. It happened to be more often in people who had developed lung cancer who hadn't smoked, and it was more common in people of Asian ancestry. And so they did this trial in Asia, tended to be women, people who had never smoked who developed lung cancer, and they recognized that this drug seemed to work really well in some people, many more than 10%, but not in everyone. And in the lab, at the same time, a couple of scientists were recognizing that the tumors from the people who had these dramatic responses, their cancers had this specific gene mutation. If they looked at the EGFR gene, they found that there was a mutation. And they knew to look at EGFR because they knew the drug targeted it. But this sort of got everyone to think differently and realize, oh, if we figured out what was going on in that particular cancer and we had a medication that could target it, then these people were going to do dramatically better, because the people whose tumors had that mutation, dramatic responses to this drug, and the people who didn't, even though they themselves looked the same as the people who had these great responses. Their tumor didn't have that mutation and they didn't respond at all. And so it got us away from the, how does the person look? What does the tumor look like under the microscope? Then we pick the treatment to, how does the person look? And then what does the tumor look like under the microscope? And what do the genes of the tumor look like? And we put all those things together to help determine what's the right therapy. And now we can look for 15 different genes in lung cancer, where if we find them, we're going to have a specific treatment, and not just one choice now, but many, many, many. That's sort of been an explosion of therapies. But the other part of precision therapy, that's really the precision part of it. But we also now have immune therapies, right? And so when we think about best possible treatments, we have to think about that too, and that's only been around a little bit more than 10 years now. And it's interesting because with the simpler tumors where there's a single gene mutation that's sort of the root of it, those are harder for the immune system to see as different because they're more similar to normal cells because they only have that one change. But in other types of cancers where there are a lot of changes that have happened, the immune system's trying to recognize it, but these newer medications give it a boost. So it does a better job of recognizing and treating it. And so when we talk about the precision therapy, it's looking at what do we know about the tumor? Does it have a marker that the immune treatments might work, which is a particular protein, PD-L1? Does it have any of these gene changes where we've got specific treatments that we know will work, but only if that mutation is there in the tumor? And then what about the person? How strong are they? How frail are they? Where is the cancer grown? What are their preferences as far as how hard they want to push against the tumor or not? And then it's a conversation about all of those things and talking about, can we do a targeted treatment alone? Can we do immune therapy alone? Do we bring in chemotherapy either by itself or in addition to one of those options? And how aggressively does the patient want to go through those treatments? What are their true goals, right? Because nobody wants giving the most aggressive, but it's how hard are they willing to, how much are they willing to risk in some ways with potential treatment side effects? It's all of those. It's a very complex part. So to me, that's all precision therapy. Even though I think for some people the definition is what's the mutation in the tumor and then how do you move forward. Yeah. And I keep emphasizing it's mutation in the tumor because it's not in the rest of the person, it's just the tumor. And then that leads back to the screening because we still haven't figured out if there's anything we can find within the person that helps us know that they might be at risk for lung cancer. We know that for breast cancers and some other things, but not necessarily for lung cancer, and so that's another aspect of the research.
I love that. So precision medicine in and of itself is also very complicated, right? And it's not just targeted therapies and it's not just immunotherapies. And I love how you touched on that sort of shared decision making and that, again, that whole person conversation, goals of care or goals of treatment for the person diagnosed in particular. So stepping back for a second, when we think about these diagnostics, and doing this type of biomarker testing, comprehensive biomarker testing, so that we can catch all. There are two different types, right? A tissue biopsy and a blood biopsy. Can you explain sort of pros, cons, which one?
At this point, we still need to have some of the tissue from the tumor to look at under a microscope for us to be 100% confident it's cancer. In my many years as an oncologist, when my turn to rotate through the hospital and take care of patients where we're not sure what's happening, definitely had patients where you look at them, you look at the scan, people are pretty sure it's cancer, but then they get a biopsy, it's not. It's an infection, it's something else. And so or it turns out the cancer isn't the kind you thought it was. And the only way to know that was to see what it was under the microscope and do some testing on the protein. So getting that initial tissue diagnosis remains really important, but sometimes there's not enough of it to pull the DNA out of the cells and then do the testing for the molecular. With the blood biopsies, what we're relying on is the fact that as any of our cells die, including cancer cells, they're releasing little bits of DNA. And those little bits of DNA from the tumor, parts of it are the parts that are different from the rest of the body. And so if you can catch it at the right time and pull some of that out, then you can do the molecular testing and look for those little bits of the tumor in the sea of all the other bits that are the normal DNA. And so that's been really exciting technology. And some of my colleagues at Stanford, Max Dean and Asher Leazaday, are some of the global leaders in that. There are many, many other centers as well. They're not the onlys, but of course they're the ones I work with. And now at a point where for some of my patients who come into clinic, including Dr. Lin when he was first coming in, there's tissue, but it takes a little longer to get those results because you do have to do these extra steps. With the liquid, you just draw the blood, and then you can do the testing on it pretty right away because the DNA is already circulating. But the DNA, sometimes the tumors don't shed that into the blood, so blood tests can be negative when a tissue test is positive, and sometimes there are things that don't work when you're trying to do the tissue test, or you biopsy a part that doesn't necessarily have the mutation, because as time goes by, some areas do and some areas don't have all of the different mutations. So there are pros and cons to both. I think what's really exciting is seeing that as the tissue biopsies evolve, we're trying to get faster at being able to extract the DNA and get the testing done. And there are more things that we can test from the tissue. But with the liquid biopsies, it's becoming faster and faster. And that's what we really want, because we want everybody, if they're going to have a lung cancer diagnosis, to know all of that information as quickly as possible so that we're not having to wait days or weeks to be able to pick the right treatment to start right now. Yeah.
So is it still, and I think you said it, but I want to reiterate, the cancer cells might not always, or the DNA possibly identifying a mutation might not always shed in the blood. But if we do see it in the blood, we know it's there.
Absolutely,
Yeah.
because these are things that you wouldn't make a mistake, right? The way that the tests are designed, if it's there, it's real. But if it's not there, you might have missed it.
Yeah.
Yeah.
So you still have to wait for tissue.
So you still, sometimes. And we can use those liquid biopsies and tissue biopsies, obviously right at the beginning is the most critical. But because the tumors can change over time, especially when something that had worked stops working, that tells us the cancer has changed somehow. Trying to figure out how it's changed can also lead to the next level of precision medicine where we can better figure out the next treatment to go to. Yeah.
So we talked about a little bit about diagnostics from a biomarker testing standpoint, but staging is also important, right?
Yes.
So I know, Dr. Lin, you discussed your brain MRI. So what does good look like even outside of biomarker testing when we're looking at trying to stage a patient?
So for a patient who's newly diagnosed, and I think different healthcare systems are different. But in the United States, especially in academic centers or in well-funded centers, a PET scan can be incredibly important for lung cancer staging because it helps us see if the cancer might have gone to bone, might have spread to lymph nodes that are in other parts of the body that we don't see as well on the CT. And then a brain MRI to help us look in the brain, unless it's a very, very small stage 1 tumor. We don't always do it in that setting. But when you get a PET scan and it shows that there are lymph nodes that are involved in the chest, we also have that the tissue then becomes important because there are other things that can cause lymph nodes that are slightly bigger in the chest or involved. So things like other kinds of infection that someone might have had their whole life and not known about, so slow-growing infections, or sarcoid, other things. And so we still have to confirm. And that's why that's why it's so complex and all these different things work together, because just having one piece of information doesn't necessarily tell you the entire story or help you to decide what's the best thing to do for a patient. Staging is important only in as much as it helps us know in that conversation, what should we do to help this person?
And I think, and not all drugs, particularly when they're first approved, are approved at all stages of disease. And I think it's also really important now when we're thinking, stepping back to the biomarker testing for a second, historically we didn't do it on early stage patients. And now, is it important that we do it on these folks that are diagnosed earlier and surgical candidates?
Absolutely. So with lung cancer, for those of you who don't think about staging all the time, right? There's a very complex staging system now, but sort of the simple version of it is a stage 1 lung cancer means it's just a single area that's grown in the lungs where there's cancer. And oftentimes those can be removed by surgery, or if someone's not going to be able to tolerate a surgery, very focused radiation. And that can cure the majority of people. If that cancer figures out how to spread into lymph nodes, and if you've ever had a cold and felt something lumpy on your lymph node, so they're a part of the immune system and surveilling what's going on in the body. But if the lung cancer figures out how to grow in lymph nodes that are in the lung, that becomes stage 2. It can still usually be removed by surgery, but the rate of cure has come down. And we want to add additional treatment to try to help. With stage 3, that means it's gone into that center, the mediastinum, we've used that word a couple of times, that center part of the chest. And then surgery alone is not going to be able to be enough. Radiation and chemotherapy can be helpful, but we also then bring in immune therapy or the targeted therapies when it's a few of them have been shown to be helpful. And then stage 4 means that it's spread beyond there. And stage 4 can be, it's nodules that are just in one lung, or it's in just both lungs, or it can have spread everywhere. And unfortunately, Dr. Lin had a much more extensive spread of his tumor by the time it was found than many people do, but fortunately doing very well most of it now. And so when we think about that, so for stage 4, that's where we still don't so much use the cure word, but I have many patients who've now lived many, many, many years, and so what is the importance of that word? It's a very powerful word, and living without any evidence of disease and without any treatment. But if you can live many, many years in a full life and be on treatment, is that really that different? Psychologically, yes. But we have to strive to help people live as long as possible, feeling as well as possible in that setting of metastatic. And that's where we try all the different things and try to develop new treatments, because those are the people who need the most help right now, right? Stage 3, we can still cure people. And we've learned in the last few years how bringing in immune therapy for some people can really make a difference there, where bringing in the targeted therapy for some people can really make a difference, and different ways of combining the radiation and the surgery with the chemotherapy and those other treatments. And we've really moved the needle quite a ways as far as how many people can be cured with that. Stage 2, it's the same, even more impacts in bringing in some of these treatments. But again, not everything works for everybody, and everything that we do has some risk. And so trying to make sure that we treat every patient as precisely as possible, getting back to that precision medicine. And even in the earliest stages, if we don't know, then we don't know about what to do. And so doing the molecular testing as part of that, looking for the EGFR mutation and ALK. And then some of the others as well, because they can help us say, this tumor is less likely to respond to immune therapy. Even if the targeted therapies might not help, we would be risking harm without as much benefit. And so it's all these things to weigh in on that decision process. But more information is always better. And in earlier stages, you also have the time, because a lot of those targeted therapies aren't going to come in right at the beginning.
What about palliative care?
Yeah. Palliative care is so important, but what does it mean, right? So palliative care is thinking about the symptoms, and you talked about, how important the symptom management is. That is something that, as oncologists, as primary care doctors, a lot of what we're trained to do is think about symptoms and how to manage that. But in the setting of trying to fight a cancer, sometimes the thinking about the symptoms becomes the second part, versus trying to figure out what are we doing to make sure that the cancer is controlled. And it needs to be part of that conversation all along. But the palliative care doctors, they are focused solely in symptom management. And so they have some additional tools and ideas and concepts that they're able to really partner and bring in. So important, mostly in the stage 4 setting, but also with symptom management as people are going through aggressive treatments for stage 3 and 2, and even sometimes 1. Right after surgery, having some conversations about symptom management can be helpful. I think people also associate palliative care with when the treatments are no longer working and someone's thinking about end of life. But palliative and palliative care is that, and that's a really important part of care for someone in that part of their kind of cycle of treatment. And it's also a lot more. right?
Yeah.
It's thinking about, because if you're not managing symptoms, you're not really allowing that person to live their best life as they're going through treatment, and that's really the goal.
Yeah, and I think one of the things that I've noticed in talking with people over the years is sometimes they're concerned about sharing any side effects they might be having with their healthcare providers for fear they're going to be taken off of a therapy that might be working for them. And this is, again, it's a crossroads, and it's a conversation with your providers, because the sooner you can get on top of those side effects, the more likely you are to actually be able to stay on therapy. And ensuring everyone that palliative care and end-of-life hospice type care are very different, both supportive, but very different. And what about access to support, education, community? I know Stanford has a support group. Yeah.
We do, and we always talk to everybody about GO2. Yeah. I think that going through a cancer journey is not something anyone expects to have to deal with, even people who are trained in medicine, like Dr. Lin. And there's so many different aspects to it that it can be incredibly impactful to have other people who are going through the same things and can be a support. And that's, when you founded the Living Room so long ago, I'm looking at Bonnie, and many of you are familiar faces to me because of this group over the years and in other settings. And it's so incredibly impactful. I think that it doesn't work for everybody. Not everybody feels as comforted by seeing other people going through what they're doing, what they're going through. And of course, it's a different journey for everyone. And I always caution my patients, if they do go to a support group, you can't hear one story and even when it's a wonderful story, assume that will be you. You can hope that will be you. And I think that can be really important too. When I'm talking with patients and talking about, well, what might happen, when I'm thinking the good outcomes, I'm always trying to make sure I'm thinking of someone who is a real person who has been through it and has done well, so there's a truth in it, right? And I think for someone to have met people who are that truth of doing well is really, really important, as well as having someone you can talk to about, well, what about this side effect? What about this? Because someone who's lived it is going to know more about what to do about it, even than those of us who are trained, and that can be also really, really important. There are also a lot of other ways to get support, though. Not everyone wants to be as open and sharing about their own story with a group of other people. Social workers can be an incredibly important part of the team. Great folks. And then the support groups, and then just everyone has their own support network. And I think that's so important, and whether that is family or whether it's friends or whether it's someone that you met in the doctor's office, or, there are a lot of different ways, but just to recognize the importance of that support. Bryant, Dr. Lin talked about that also with the spirituality. And I think, there's the spiritual aspects of it. There's also just the social interactions aspect of it, and finding, ways that you can keep yourself wanting to continue and willing to face that next step, and finding the meaning. And why are you going through this? How are you going to keep going through this? To continue to find what's joy, even when it's hard to see that.
Yeah, and there's cultural differences too, right? That absolutely play a role. I remember when we first started this meeting, it was actually right after that event, or during that event. I was speaking with I'm pointing to a picture on the wall for those of you online. And she had said, I was diagnosed with lung cancer a year and a half ago, and I've never met another lung cancer patient until this very event. And I thought, man, and she really wanted to, right? But she just didn't know where to go. And she was looking to the breast cancer community, which was very well established, and people were banding together and supporting one another and doing all of that. So it was, one of the things that inspired us to go ahead and try to create this for those who want to. And I guess, really, when you think about it now, there are so many different types of support available. It does not have to be in person. You look at, there's online groups. They're not always face-to-face. Some of them are just kind of typing and talking to other people in online communities. And there are just so many more options, I think, now. I mean, I remember when mom was diagnosed, she wouldn't have come to a support group to save her life. She never would have done it, right? Although if we could have drug her to, and if we had known about any, my sister and I would have, she would have enjoyed it and met so many really amazing people. But you know, Mike.
I'm sorry, I talked loud enough. The problem with that is you're afraid you don't know how to choose a doctor because you don't even really know what to ask for.
Yeah.
And I never did. I didn't. It's like, no, I don't need to talk to anybody.
Yeah.
So it's something we really have to work on.
Yeah.
Yeah. Yeah. And it's, again, part of that treating the whole person and identifying their needs as healthcare providers. So you touched on this a little bit, but at progression, what needs to happen then from a precision sort of standpoint?
So we spend a lot of time talking about when someone's first diagnosed and what's the information. When that treatment no longer is working well enough against the cancer, or if it is just not tolerated, right? There are two different things that can happen where you need to think about the what next. We try to get information about how the cancer might have changed. The root of it is going to be the same, but perhaps it's developed a new mutation, and that could guide treatment, especially when we're dealing with the precision targeted treatments. When we're dealing with immune therapy, there's a lot of research being done now about, do you continue it, do you not continue it? If you continue it, what do you add to it? What other strategies should we be thinking about? When the reason someone might not have been able to have either of those, thinking back, is there a reason that we could think about differently now as something new will come along? And obviously, talking about clinical trials, which are not an option for all people and aren't the right choice for anybody at different times, but can be the best choice for some people at other times. Making sure that that's part of the conversation as well. And that's also where the patient groups can be so helpful. As you mentioned, there's some online and some that are dedicated to people whose tumors have specific mutations, and they, are really quite engaged in knowing what all the research is and who's doing which trials. So that can be really, really helpful too. Yeah. So, but it's, again, that conversation about what does the person really hope to be getting out of treatment at this point? What do we know about the tumor that could help guide that? What options are there in addition to the standard options, and then to make that decision together. Yeah,
I'm glad you brought up clinical trials. We've had whole sessions dedicated to sort of, taking the veil off of the myths around clinical trials and what they all mean. We have folks in the room who have participated in clinical trials, and I think it's to your point, maybe not for all, but for some, it's an important part of this precision sort of medicine place. And quite honestly, were it not for people participating in clinical trials, we wouldn't have these amazing, precision treatments to offer folks. So if there, I guess without taking too deep a dive, and I am being mindful of time because we're almost up, clinical trials are not for everyone. At what point might it be a good idea for someone to talk to their provider about a trial?
At any time there's going to be a transition in treatment. So whether it's at the first diagnosis, or whether it's time to think about that second thing, or the third thing, or the fourth thing, it should always be asked about. And actually at Stanford now, whenever I'm going to make a transition for a patient, we have a box that pops up of clinical trial. Why isn't this person going on a clinical trial, right? And so just to help refresh that, right? Have I thought about it? Have I talked to the patient about opportunities? Have I looked beyond just what's here, if that person is willing to and interested in traveling, to sort of make us stop and have that question? And we hope everyone is doing that as well. And sometimes the answer is no, this isn't the right thing to do right now. But if we don't stop and think about it, it never becomes an option, right? So.
Yeah. Time is up, and before I ask their last question, because we didn't get time to necessarily get to it today, but second opinions. You guys have those of you who are have been coming here for years on end. I think for a lot of people are such an important part of the diagnostic and treatment process as well. Whether, to your point, it's upfront or when something changes. We know that not all oncologists have the benefit of specializing in something like lung cancer. They, they have to treat whatever type of blood or solid tumor cancer walks through the door. And in a time in medicine where things are so incredibly complex, it's never a bad idea, if you can, to reach out for a second opinion with someone who does have the benefit of specializing in your particular diagnosis. Okay, with that being said, Dr. Lynn, I'm going to go back to you, and I'm going to ask you both this final question. But what do you hope people most take away from this conversation tonight?
I think, from the topics today, you're really not alone, right? And, I've had so many people reach out to me with emails because they saw some sort of media coverage about my story. And I do feel like there are a lot of people who feel alone. So I think, to me, a great credit to you, fantastic organization. You're not alone. There are a lot of resources and people you can connect with. And that, to me, is very important, even as a physician with lung cancer, connecting with people I've never met, strangers who've gone through what I'm going through, was really important.
How about you, Dr. Wakelee?
I think just to reflect on how much we've learned about lung cancer in the last 20 years, really it kind of took off around that time, and how that has led to so many better options for patients who are diagnosed. And we have a lot of work to do still in trying to understand why people are getting lung cancer. How do we improve screening so we can find it earlier and cure more people as we continue the work on all of the new treatments that are also making that impact. So
that's great. Thank you both so much for coming and talking with us tonight. I thank you from the bottom of my heart, as I know our community does. It means so very much. I do have to do a little bit of housekeeping, per usual. Our next Gathering Hope is May 13th. If you're not familiar with Gathering Hope, it's sort of an around the room, if you will, where people who want to can participate. Camera on, camera off. You can talk, you can just listen. But people sharing their stories, having conversations about where they are now, supporting one another through varying aspects of a lung cancer diagnosis. So that's May 13th at 11 a.m. Pacific. And then our next Living Room is on May 20th, when we are having a conversation about coping. So some of those big feelings that we touched on a little bit ago, and what that looks like, what GO2, not just GO2, but what GO2 and others are doing to help support people with some of the big feelings that come with a lung cancer diagnosis. So that's May 20th, and that's with Sarah McHale from GO2, who's a licensed oncology social worker that runs our Mind Over Matter program, and Allie Sachs from Triage Cancer, and is also on our GO2 Scientific Leadership Board. So we're really excited to have them next month. A huge thank you again to these two. Big round of applause. Sorry. To all of you in the room, again, all of you watching live, we bring this, we do this for you and with you in mind. So thank you all for your continued support, Onyx and Ash and Penn Media, for all of the behind the scenes things that sort of need to happen in order to bring this out to our community. Michelle Zay back there for monitoring the online chat. I want to give a shout out to Bridget from Penn Media. She's in the back, who helps us to produce this programming. It's her birthday today. So a big happy birthday to Bridget. And then, of course, our supporters, Amgen, AstraZeneca, Bayer, Boehringer, Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, and Takeda Oncology. Without their commitment and their support, we would not be able to bring you guys this programming. So thank you all. Until next month, please get food if you didn't, and there's dessert. So thanks, everybody.
thank you.
Thanks, Scott.
So I'll be brave if you're brave. I'll be brave, but only